Well, thanks for the invite to come, although I had a little trepidation when it was Betty who called me on the phone and said, I want you to talk about cancer and NF1. I said, well, sure. You know, when Betty asks you something, you just say, sure. Then I started thinking, what in the world am I going to talk about? I'm not an oncologist, so I'm not going to talk about clinical trials. And I'm not an epidemiologist, and you'll see as we go through the slides that I've taken a perspective that fits me better than it does either one of those other two. And so you'll just have to bear with me. I think that the thing that I did feel that I could contribute was just 30 years worth of working in the NF1 field and meeting a number of families. And even if their child didn't have a cancer that they were dealing with, there might have been a parent who was dealing with one of the conditions. As you'll see, one of the real learning points is the key cancer that we need to figure out a cure for is the MPNST, the malignant peripheral nerve sheath tumor. And so with Betty asking me to give a talk on cancer risk, it was very easy for me to focus on the MPNSTs. And that was, the reason it's so easy is because what has come out in the last couple of years is the high cancer risk for MPNSTs. And the data is now there. Even though I'm not an epidemiologist, I can read these papers, but it takes Betty to make me give a talk like this that I am forced to read them. So I've tried to condense some of the information that I can't read in those manuscripts without spending a week and a half. Until I actually am forced to sit down and go through line by line. And so hopefully I'll give you a summary of really what are the cancer risks and what is the best study that's now showing us what those cancer risks are. But I also view myself as a reclinologist, and is that a term anybody's heard? What is a reclinologist? It's, Dr. Riccardi. Anybody know Dr. Riccardi, Vic Riccardi? A couple? Yeah, there's a clap, right? So he's a wise man. And when things came about over the last 30 years, as we've learned more and more and more about NF1, he's used the term, anybody who's investigating, anybody who's doing any kind of research or any kind of clinic where you're meeting people with NF1, he likes to call them reclinologists, and that's for Dr. von Recklinghausen, who was the initial pathologist. He's a pathologist, by the way. He's a pathologist who recognized that neurofibromas were a feature of a specific condition. So with that, I want to give you 5 things you need to know. So there's going to be a lot of slides that we go through. All I want you to do is remember 5 things. Maybe 3 things would probably be better, but 5 things. So NF1 is a tumor suppressor, and we'll get to that. I think you've probably heard enough talks now that you probably got a pretty good sense what the Wrasse pathway is. Well, Wrasse is an oncogene, and NF1 is a tumor suppressor that works with that oncogene. But we'll go through the pathway. But this is the key one, is that the MPNSTs are the most concerning cancers in NF1. I also want you to know that the next on the list, primarily for adults, I think in pediatrics we see lower grade gliomas, lower grade brain cancers. But individuals who are older, they are more likely to have a brain cancer that's likely secondary to a double inactivation of NF1 as they are to have MPNST. Probably not quite the same relative risk when you look at the population risk, because brain cancer we're a little bit more familiar with than this MPNST, which I'd like to just call a sarcoma. It's in the sarcoma field, or soft tissue cancer field. And then we have to have a little discussion about breast cancer and where are we going to place breast cancer. Are we really going to change how adults with NF1 are evaluated, are surveyed over time based on a link to breast cancer and NF1? Because that's a big deal. I'd have to say most guidelines are becoming more lax as far as looking for breast cancer, relying more on palpation than the imaging. And then finally, we'll let you know that the surveillance for NF1 cancers is really not clear. There's been the recent publication on the guidelines now for adults. But that's expert opinion. And there'll be a call to, that really is a call to say, okay, now we know what we don't know. I think Dr. Welling actually said that. You got to know what you don't know before you really can take a step forward. So with that, this is how I felt when Betty gave me the call. So where do you start? And what I said was, well, I can break it down a little bit. So I've identified 4 perspectives of cancer risk. We can go into the historical component, talk about cancer, but there's a lot of information on that, as you well know. The first cancer case was on papaya script rolls back in Egypt in 1600 BC. And then the philosophical component of why me, and maybe the religious connotations of there's something I did in my previous life that I'm now subjected to cancer. But I don't know anything about those 2 things. I'm just going to talk about the biologic perspective, and then I'll switch to the statistic perspective. So we'll do about half of biology and then another half of numbers. So I figured maybe by the time we get to numbers, everybody will be awake again. So as you know, cancer can hit any organ system primarily, and there's billions of cells in our body. I guess the remarkable thing is that all of us don't get cancer sometime in our lifetime. It's just the process of having cells divide and these stem cells to continue to make an organ do what it's supposed to do. I know that cells dedifferentiate and they get out of that cell cycle, but there still are stem cells that need to rejuvenate organs and rejuvenate tissues. So it's not surprising that our lifespan really is somewhere between 70 and 100 years now. But any of those cells, if any cell in that in the body were to undergo, and I've drawn the cell, you can see the nucleus. I don't know if this shows up on the screen, but inside the nucleus is where the genetic material is. And it just takes a mutation that doesn't get fixed, so a random mutation that occurs that doesn't get fixed within that DNA, that may be enough to propel that cell onward to become a cancer cell. And this is a nice cartoon to depict that within normal tissue, there can be a cancer cell, any cancer cell, and all of us are susceptible to this. One key number to keep in mind, what's the likelihood, our lifetime risk of developing a cancer in our lifetime? So 50% for men and 30% for women, perfect. If you combine those together, we're talking about 38%. So a lot of us didn't think about that. Certainly me in pediatrics, I wasn't thinking about that. So that's a pretty high number when you actually sit back and think about it. And it's not surprising when it just takes a couple of cells, rogue cells, to take off and start growing. Well, the treatment, as you can see, if you caught this tumor early, you might be able to get that in situ. You might be able to get that tumor that's in situ out pretty easily and move on with your life. And that may be one genetic change that occurs. But what happens when multiple genetic changes occur in that same cell? And it starts growing faster and it starts metastasizing. Well, then it becomes much more difficult. So simplistically, this is one way to view cancer. The best way to treat it is to find it early. So one of the examples of those cells where it takes one change is the Wrasse protein. So these Wrasse-associated cancers, they're probably the most common of all the genes that are mutated in cancers. Wrasse is top on the list. And it was back in the 1980s that it was initially identified. And we are still, the National Cancer Institute is still working diligently trying to find a small molecule to inhibit Wrasse signaling. So if you look at the number of those cancers with a mutant Wrasse, KRAS, 85% of pancreas and lung, colon cancers. HRAS is in about 1%. Bladder cancer is where we'd see it. So Wrasse is a key player. And this just depicts a cartoon of showing where Wrasse fits in. And I think, at least Dr. Wiedemann, I think she had shown where Wrasse sits. It's right on the inside membrane of every cell. And it's attached to that membrane. So when Wrasse is loaded up with GTP, it will send a signal down through RAF, and then it should be MEK, and then down through ERK. So this is where the MEK inhibitor works. It's right in this pathway. But what you really need to know is, how does NF1 have to do anything with this? And those who have been to some of these conferences before, I think you know that NF1 downregulates Wrasse. And it's now been, 20 some odd years, 25 some odd years, since the gene was identified, and an understanding of the biology, that it's still the primary role of NF1 is to simply downregulate Wrasse. So it's an amazing thing. And so if we go through, this is something you just need to know. And if I can pull this out for you, here's Wrasse, and it's bound to GTP. And when it's bound to GTP, it sends a signal to the rest of the cell. And this is to say it's a proliferative signal for that cell to divide and potentially grow. And here's NF1 right here, and all it does is it stimulates that intrinsic GTPase of Wrasse. So when Wrasse downloads its GTP to a GDP, just throwing off a phosphate group in the process, then that downregulates the Wrasse signal, and this signal gets muted. If you lose NF1 right here, you don't have that signal, you don't have the GTPase being activated, and you get a doubling of the signal. So if you just go back and forth, you can sort of see. Makes it easy, right? It's that switch that Dr. Wiedemann had shown us. So where NF fits in, the term that we use, even though Wrasse is an oncogene, it's still in most individuals, and certainly within individuals with NF1, that Wrasse is still wild type. It has not undergone a mutation. But what's lacking is the the effectiveness or the function of neurofibromin, which is the NF1 gene product, neurofibromin. So this is how tumor suppressors work. There's plenty of tumor suppressors in biology, so it gives us a paradigm. But in the non-NF1 cell, so somebody who doesn't have NF1, you have 2 copies of the NF1 gene, and they perfectly compensate, and you move along in life with Wrasse being appropriately regulated. If you have one NF1 mutation, usually it's an inactivating type mutation, now you have a little bit too much Wrasse being signaling down to the downstream effectors, so into the nucleus. So if you get that double hit, you knock out both copies. And now that Wrasse is really going to town, and those cells are starting to divide. And this paradigm of a tumor suppressor was initially identified by Dr. Knudsen back in the late 70s, early 80s about retinoblastoma. So this is a fairly understood process. So the timing of this second hit, right? So let's go back. If you're born with NF1, every cell in your body has one mutation, one inactivating mutation of NF1. And what causes that second hit to occur? We really don't know. We presume it's a random process that occurs. And this is an idea of instead of thinking of that original photo where you had normal, or figure where you had normal tissue, and then it took 1 hit and then 2 hits and 3 hits before that cancer grew. In individuals with NF1, every one of their cells has an NF1 mutation. So we say plus minus. So every one of the nuclei in this cell, which I'm depicting as a part of a peripheral nerve sheath, has haploinsufficiency or inadequate amount of NF1 gene product, neurofibromin. But likely, and I'll go back one, likely sometime during embryogenesis, we think, and I'm focusing now on plexiform neurofibromas, sometime during the embryo as it's forming, nothing that a parent's being exposed to, this is just a random process. Genetic changes happen all the time. So at some point, there may be a mutation that just occurred in just that one cell. So now we've got a double inactivation. Hopefully you can see in the very top it says NF1 minus minus. So these are doubly inactivated cells. And they probably are a little bit more primordial. This could be a or it could be a stem cell of some sort. And it's just hanging out there until some stimulation happens, and then you may get the tumor that starts developing. So you can imagine the timing of that second hit, if it was late in embryogenesis, or if it was even after somebody's born, there's very few cells that might have been divided from that original mutation. But in the case of an early in the embryo stage, you could have many precursor cancer cells that are just hovering within that peripheral nerve sheath. So the sooner a mutation happens embryologically to lead to double inactivation of NF1, possibly that's going to be a tumor that's going to be more active. If you've ever wondered, well, why is this plexiform small and not doing much? And here's another one that takes up almost the entire limb. That may be one of the reasons. The other thing to keep in mind is neurofibromas are generally not clonal expansions. When we think of cancer historically, you think, okay, here's one cell, it mutates, and now it expands, it expands, it expands. Well, what NF has taught us, what these tumors have taught us, is that there's multiple cell types within a neurofibroma. So they're still benign tumors, and the key ones, we think, are probably these Schwann cells, that there's a small population of Schwann cells that are the minus cells. And they're the ones telling the rest of the cells that are haploinsufficient around them to start growing, start proliferating, and act a little different than you would otherwise. So it's really key that if you just had a mutation of a Schwann cell, at least in the mouse models, if you just had double inactivation of one Schwann cell, in the absence of any other changes in the periphery, you would not see a tumor grow. It requires having haploinsufficiency of the other cells around it, which is kind of unique. So we now know that the tumor, the microenvironment, is very important. It's not just a clonal expansion of cells, it's actually those cancer cells are relying on cells nearby to enhance its growth, enhance its proliferation. And this is just another example of tumor microenvironment, and I wanted to show it primarily because unlike the plexiform neurofibromas where the cells are really not dividing, those of you who have had a child who's had a biopsy, one of the key things that you're looking for from the pathologist is when they come back and say, we looked for mitoses and we didn't see any. Then you know it's a benign tumor. In the MPNSTs, when that transition has occurred, what the pathologists primarily rely on are these mitotic spindles that they see within the tumor. And as soon as they see those, that's when the term malignant peripheral nerve sheath tumor is used in the context of a plexiform neurofibroma or an atypical plexiform neurofibroma. And this is just an example of what the pathologist may be looking for. Down below is in pink, that's the plexiform neurofibroma, and arising within it is a nodule. You can see how blue it is. That just means that there's a lot more cell nuclei. There's been a lot more cell division. Those mitoses are really taken off. And this is the cancer that we are most worried about. So that was the fun part. Maybe I ought to take a question or two if anybody has one. Because now we get in the numbers. Now we do the statistical part. So now we're moving on. And I'd have to say that I felt more like this. I don't know if you remember the last cancer slide, but where to go from here. And what was really helpful is about a year and a half ago, the folks from Finland who have an excellent electronic medical record were able to harvest, or not harvest, but they're able to identify all of the individuals with NF1 in Finland and go into the electronic medical record and look and say, okay, of all those individuals over a 25-year time span, how many of them had cancer? What kind of cancer did they have? What age were they when they had the cancer? So it made my life a lot easier. And I know Betty's not in the room, but if you see her, you can give her grief about how I had to read through that. But beforehand, I wanted to just show you, if you go to a cancer website, they are not going to, well, I should say, this is the list of cancers, and you probably can't read them up there. We start with bladder cancer and breast cancer. It's all in alphabetical order. But the key thing is, here's our lifetime risk, 38.4% lifetime risk to develop a cancer between 2013 and 2015. Other thing you may not have known, I don't know if anybody here is from Kentucky, but for whatever reason, Kentucky has the highest death rate due to cancer, 227 individuals per 100,000. But it doesn't change all that much in the other states. If you look down, New Jersey is 25th, and they have 194. So the difference between 194, 227, these are statistics, right? They're just numbers. But anyway, 85%. So if you're in New Jersey, you have an 85% chance, 85% of the chance that you'd have in Kentucky of dying of a cancer, which I thought that was kind of interesting to think about. But the key thing I wanted to point was that MPNSTs, other sarcomas, and CNS tumors are not on the list of the most common cancers that you see. So when the American Cancer Society starts talking about all these numbers, they don't generally pertain to NF1, is my sense. So let's go to it. The first study that looked at the relative risk of cancer, so this is the risk if you have NF1 to have a cancer versus the population risk. So they're just weighing it. And so it's a relative risk. So this is a relative risk ratio. And for the United Kingdom, what they found is 2.7 times higher than the general population if you have NF1. Walker tried to break it down, and so you have connective tissue, there's brain, and then there's breast. This is the first time somebody looked at breast cancer, and initially it was 1.87 relative risk. So one being there's no difference between NF1 and the general population, and here it's a 1.87. But if you looked at individuals with NF1 less than age 50, the relative risk goes up. It's now a little bit over 4. So that catches people's eye. The other cancers were not statistically significant. So even though we call this a maybe familial cancer syndrome of some nature, it doesn't really indicate that you're at risk for colon cancer, for some of the more common cancers. So it really is specific to the NF type of cancers. So here's the cancer risk study from Finland. So there's 5.4 million people living in Finland, and they assessed between 1987 and 2011, so 25 years worth of data. NF1 was diagnosed by ICD-9 codes, ICD-10 codes within their system. And so these are from all referrals, and they took a look at the diagnoses that were in the electronic record, 535 of them, and they excluded on review. About 1,400 patients were fully assessed. And then they looked at the cancer registry as a population-based countrywide registry. So anyone with cancer in Finland is going to be captured in this registry. So there was a total of 667 males, 737 females, a total of 975 families for these some odd 1,400 individuals. So it's kind of interesting. We usually say, at least in the US, about half of the families that we see in our clinic are sporadic cases, no family history. In Finland, if you do those numbers, 975 different families, 1,400 individuals, you recognize that that's about a 70% sporadic, I guess, new mutation rate, if you will, or sporadic incidence. So that's something that's a little different. And that's what I see in Japan. When I visit Japan, it's more like 70%, not 50-50. So what did they find? They found, out of those 1,400 cases, they observed 244 cases of cancer. They expected, from the population risk, 48.5 cases of cancer. And they compare this in an age and sex-matched population evaluation, so it's about 20,000 person years. Now that's a statistician talking. I have no idea what that means. If somebody knows what that means, then they can answer the questions at the end. But this SIR, which is the standardized incident ratio, which is very similar to that relative risk ratio. So the number that they found, remember, it was 2.7 in the UK. In Finland, it's up to 5. And they have 95% confidence intervals that psychologists tend to look at sometimes. But so let's take a look at the types of, or the incidence of this cancer risk. By age 30 years, if you have NF1, there's a 25% risk that you'll have a cancer. If you don't have NF1, 0.8%. So not only is cancer incidence higher if you have NF1, certain types of cancers, by the way, and we'll get to that, but it's usually at a younger age. And this is what struck me in my clinic, is seeing parents who have NF1 taking care of their children and then them dealing with their own cancer. And so we've now been very proactive in making sure parents are taking care of themselves even though they come in for their child's checkup. If they themselves have NF1, we really like to, we diverge a little bit. We talk a little bit more about, well, who do you need to see? Where do you need to go? Now, by age 50, with NF1, there's the 38.8%. And now the rest of the population is catching up. Without NF1, it's 3.9%. And finally, the lifetime risk for cancer, 59.6% if you have NF1 and 30.8%. So you notice Finland's a little different than the US. Not sure why. Maybe it's those saunas that they take so often. But if you look at the MPNSTs, so this is on the right-hand side of that slide. In individuals by 30, if you have NF1, a 25% chance of having a cancer, that cancer, you got that 8.5% chance of it being an MPNST, which we know is very difficult to treat. By age 50, 12.3%, and then lifetime risk, about almost 16%. So we do want to be on the lookout for those tumors. And this just graphs it. I think it's a little small to see, but here you can see if you don't have NF1, this is the risk of developing a cancer. If you do, then you can see it sort of jumps right off the page, and then the rate flattens back down. So cancer associations in Finland, the type of cancers, we already talked about the MPNSTs. So remember, any cancer relative risk ratio is about 5 MPNSTs. It's 2,000. So this is a rare cancer, except in the context of NF1. So if any pathologist were to see someone come in and have a diagnosis of MPNST, they better be asking that question, does that individual have NF1? And by and large, I would say over probably 2/3 time, they would be right that they do. So then we look at brain. Now, brain isn't divided up into different types of brain cancers, but you can see it's 37.5, so that's a pretty high number, relative risk ratio. 37 times more likely to have a breast cancer if you have NF1 than if you're in the general population. But remember, the general population is getting colon cancers, and they're getting these other things that individuals with NF1 are not more susceptible to. So GIST, gastrointestinal stromal tumors, I had a discussion with somebody yesterday about GIST. So this is a relatively rare tumor. I view it as a more benign tumor. It's not really a cancer in my mind. The adrenal medulla, that's pheochromocytoma. I was a little surprised at that in Finland. It's 74 times more likely to affect someone with NF1 than if you didn't have NF1. And then here we get to the breast. Again, we see it's higher than the ratio of 1, so it's about 3. And when you see a relative risk ratio or an incidence ratio of 3, you're starting to wonder, should we do different surveillance? And then finally, for those individuals who have had a child with JMML, which is a type of leukemia, it's still pretty rare. It's very unusual, and they did not see any increase in leukemia. You see it's a 1.19 down here at the bottom. So leukemias are not individuals with NF1 are not that much higher at risk. So this breast cancer risk was compiled in a review by Gareth Evans. Those of you who have heard Gareth Evans, the NF2 expert that is an epidemiologist who doesn't need a microphone, if anybody's heard him talk. But Gareth is terrific at pulling numbers together, and he was disturbed by this breast cancer relative risk. And so he looked at it in great detail and compared multiple studies, and you can see here are the multiple studies. I don't expect you to have read it, but essentially these relative risk ratios go anywhere from 4 up to 11. And so his point was, it's time to institute a collaborative national MRI-based breast screening study to quantify the potential benefits and harms of patients with NF1. And I think that got captured in this, the guidelines article from the Genetics in Medicine. So that's something that a lot of clinics will be addressing here in the near future. I think we hit that. So now let me just switch, because what I'm doing okay, you're going to flash me. Okay. All right, well, I'm going to zip on through here then. So the thing about the Finnish study is I had been over there visiting, and we had just concluded, we pulled together a study that we did in Idaho, and Shannon, yeah, did you tell everybody where Idaho is? It's right there. Okay, those of you who don't know, Shannon is the volunteer of the year. So we get to see her every once in a while. So I think you ought to stand up. She says she's shy, but you can't be shy and be the volunteer of the year. So Idaho and Utah, it's about, that catchment area is about the same as Finland. It's about 5 million people. And so we looked between 1993 and 2005. This is before the Finnish study. And the risk that we came up with, we identified, let me just go to the numbers. We identified 245 cases of NF1, observed 31 cases of cancer. We came up with a relative risk ratio of about 9.6 in our area. So there's a lot of mining. We're a little different than Finland, so it's a little higher to see that the relative risk was elevated. The other thing is we looked at the different sites, and this was based on our cancer registry, which isn't the same as the cancer registry in Finland. So we got to keep that in mind. But still, brain was way up there. MPNST was down here around 5. And there's a few other cancers that were not seen in the Finnish study, but this just goes, I think, to the pathologist, and the way we capture data is going to be different in different countries. And there may, in fact, be different founders. There's a different genetic makeup of individuals from Finland, maybe not so much to Utah, since we're primarily from Northern European descent. But there's going to be some differences. We have to be aware that it's not going to be the same all around the world. But the CNS tumors that were found are primarily these astrocytomas. And so we do need to be aware, not just MPNSTs, but we've got to be thinking about astrocytomas as well. And I think, given that I can say one thing about Utah that you can't do many other places. And this is a pedigree. So those of you who've gone to the clinic and a genetic counselor has laboriously gone through a 20 to 30 to 40-minute exercise getting your pedigree. The real reason for that is trying to identify other modifiers that may play a role in NF1. And the two that I usually think about are cancer and orthopedics. So if there's scoliosis in the family, even if that person doesn't have NF1, there may be some genetic contribution that goes to the child with NF1, who now may be more at risk for scoliosis, along those lines. And so you want me to wind up? Okay. So what was interesting is we have what we call the Utah Population Database, which is a group of founders who came into Utah, and they stayed, and they had big families. And we can track them. I don't know if you can see, it's like 7 generations. So we can identify somebody with NF down here and go up 7 generations to the founder from 1847 coming to Utah and find another person with NF1 down on the other end of that. And so there's a lot of generations in between. Now they don't share an NF1 mutation, but they both had spontaneous mutations, a genetic change. And so we asked the question, is it possible that there could be a predisposition to just generate mutations in genes, big genes like the NF1 gene, and could this be a gene that could be like the canary as you go into the mine shaft to see if there's too much gas, right? So this could be, given that this gene seems to be one of those genes that's most prone to mutation. That's why there's so many individuals who are sporadic cases, where neither parent's affected, and yet the gene changes in the sperm or the egg, and now you have a child with NF1. So we looked for that, and we found our relative risk for any cancer in these clusters where there might be cancer that's hanging out. We were really thinking we might find a modifier for cancer, and we really didn't find it. The relative risk was 1.35. And Tracy Ann doesn't like when I give negative results, so I'm going to move right on to finish up with NF1, it's really a familial cancer syndrome. Remember that it's an autosomal dominant condition. The NF1 gene product is a negative regulator of Wrasse. It's a tumor suppressor. And there are certain tumors that we need to be on the lookout for. Now, these numbers were done before the finished study came out, but I just want you to key in that the cancers that we're looking for are sarcomas and these higher grade brain cancers that might be glioblastoma multiforme is the term that we sometimes use. So, 5 things you need to know. Tumor suppressor, MPNST, high-grade brain cancers are there. So, you know, those headaches that you sometimes get, there are reasons to look into that and to pay attention to symptoms. Breast cancer, it's a little bit further down, so the incidence isn't quite as high, but it's higher than the general background, and we got to figure out how to do surveillance without exposing people to too much radiation and maybe inducing a tumor that would never have come on in the first place. And with that, I'll close, but I did want to tell a little story, if that's all right. All right, so this place right here, right there, is it's still there, by the way. So that's where I started working. So at the time I was a pediatric resident and I was looking for work. I knew I wanted to do a fellowship in clinical genetics, and I was on my way to do Prader-Willi studies, which those of you who know Prader-Willi, I think there's some learning or some people that are engaged in school teaching, but that's a different condition, about 1 in 20,000 people, and they have a deletion on chromosome 15. And I was pretty excited about mapping those deletion breakpoints for Prader-Willi syndrome. And John Carey, my mentor, said, well, you know, there's this NF Young Investigator Award that you can apply for. And I said, oh, okay, I don't mind writing a proposal. So I submitted my application. He happened to be on the review board, and what he didn't tell me at the time was he had no money for my fellowship. He was sweating bullets. So he's on the study section for the Young Investigator Awards for NNFF, National Neurofibromatosis Foundation, now transitioned to CTF, Children's Tumor Foundation. And I was able to garner some funds from NNFF at the time. So that got me into the NF field, working with Ray White. And I was originally looking for clonal expansion of cells, Schwann cells, out of neurofibromas. And about 2 weeks after I joined his lab, they lost 2 clinical coordinators who moved on to other educational pursuits, and he stuck me on the lab doing pipetting, which I loved. And so for the next 2 years, we then focused on finding the NF1 gene. So I didn't do anything that I said I was going to do in the Young Investigator Award, but I don't think Annette would begrudge me for that. What I didn't know, and this is the good part of the story, they also gave a Young Investigator Award to Peggy Wallace. Anybody from Florida? No Peggy? Right on, okay. So Peggy was working in Francis Collins's lab at the time. And it struck me as I was sitting in this room, plugging away at the time that we thought we really had the gene and we'd submitted it to cell, and I get this phone call, right? So we just sort of wrapped everything up. And it's Peter Bellerman, who was the Annette Bacher of NNFF at the time. And he's calling me. He's flying over. He was in Idaho, starting up or getting a clinic going. And he's flying over top and he says, Dave, what's going on? He's the president of NNFF. And I couldn't say, oh, nothing. Nothing, don't worry. See you later. Next time I see you. So as it turns out, that was like the week that we had just submitted the evidence that the NF1 gene was identified. So I realized then that Peter was a pretty crafty guy. You give Young Investigator Awards to the 2 competing labs, and you let them duke it out, and you see what happens. And we were having this discussion about how valuable competition is to move things forward, and I think Annette hit it right on the button. So with that, I'll close. Thanks. We got time for questions? A few questions? Okay.
Yes, sir. Is there... I've had melanoma.
It's on.
I've had melanoma twice. Is there a connection with NF1 and melanoma?
Right, so I think everybody can hear that question okay. And so far, I've not seen that there's been an increased relative risk or incidence with melanoma. The key thing there is there's different types of melanomas, as you're probably well aware now, and one of them goes right through BRAF. And BRAF, remember, is one step up from MEK within that Wrasse pathway. And so it makes sense that there ought to be more associations of melanoma and NF1 because of that. But remarkably, there really isn't. So even though it's the same pathway, it must be a different cell. We know that the neurofibroma is really working hard in Schwann cells and in melanocytes with the cafe au lait spots. But yet for like basal cell, not basal cell, but at the basal melanomas at the base of the skin, it doesn't really seem to be associated. Did anybody tell you differently? I'm just curious.
Excuse me. I did a search through PubMed.
Uh-huh.
And I don't remember the country. It could have been Finland. I'm not sure. But that revealed that there could be.
Okay, but in their studies, they didn't see melanoma as being a highly associated cancer for some reason.
It was a European country.
Yeah?
So it's not, I don't think that, as you said rightly so, I don't think there is a connection between increased risk for melanoma with NF1, but NF1 plays a role, is one of the big important mutations in melanoma. So it's kind of the other way around. So when you have melanoma, yes, NF1 plays a role. Whether having NF1 increases the risk for melanoma, there I agree with Dave.
Thank you.
So I just wanted to make one quick comment, is that first of all, Dave, you joined us and you stayed, and I think that deserves an applause because you're a big name and a big person in this community, and I'm very happy to have you see.
Yes.
Just a quick question. Have you found there's a difference in response to chemotherapy for cancers in patients with NF than without?
Dave, I just have one quick announcement before you respond. So if you are staying at the Hilton and you have not checked out and you're leaving today, you really should do that right now because they need to turn things around. So thank you.
Okay, so I have to tell you, I'm not an oncologist, and I think the question was, is there a difference in response to therapy if you have NF1 versus if you don't?
Yes.
Right, so there's been a couple of, and let's just focus on the MPNSTs. And there had been, originally, there was a thought that there was a difference if you had NF1 and an MPNST versus if you were sporadic. And then it flipped, and then it said, yes, it did matter, and now it flipped again with the death studies that they found in Finland. So it really is, this is why I think statisticians do so well, is the same numbers, they can shift things a little bit. And so I think right now, I think most people would say this type of sarcoma is tough to deal with, and chances are you might have found it a little bit later if you have NF1, because a lot of times it's in a pre-existing plexiform neurofibroma, and I don't know how people accommodate so well, they cope so well with having a plexiform, that transition where there's new pain, new onset of pain, you may not pay much attention to it. So it might be a little later diagnosis. And so that's the tricky part, is knowing that if you didn't have NF1, would you come forward sooner because here's a bump that you had never seen before, versus if you had NF1, you got this bump that's been there for a long time, and now it's just changing a little bit. So it's hard to compare. It's not quite apples to oranges, but it's maybe along that path. So the response for MPNSTs, though, is still not good, regardless of if you have NF1 or not.
Right. In general cancer, you don't have an answer for it.
Well, I don't, not as a geneticist. There is,
Right.
that information may come. If anybody else knows, please share. Yeah.
Do you think we should be talking about prophylactic mastectomy in our adult patients?
I don't know. Thanks for asking that. I think that is the question. I would say no. I can put on my genetics counselor hat now and say that we give the data. we lay it out, and we let the families decide what's the next step. And I don't think that this risk is high enough where anybody would really be making that recommendation at this point. Maybe in 10 years, if we get more data, we might. But again, we can make those recommendations all we want, and it's the person who receives that information that has to, there's just so many things that are going on in our lives that one little recommendation is just one piece of it, is how I would do that. Yeah.
I have a
Okay.
Gwen can go first. Gwen? Yeah. Okay. I just want to share with you that my daughter, who is 30 now, when she was 16, she had a low-grade MPNST in her lower lumbar. That was in 2004. And then in 2008, she had a high-grade MPNST in her sciatic nerve. And she's still with us today. She's a survivor. So I just wanted to share with you. It can happen.
It can definitely happen. So I didn't put that in perspective. So if you're diagnosed with an MPNST, the 5-year survival is about 25%. Mm-hmm. But it's 25%.
Exactly.
Right? Bingo. Good.
Yeah.
I have a
Last
mic now.
question.
All right, so a question from our side of the room. Is there a higher risk of an MPNST with the number of plexiforms that you have?
I don't know that we know the answer to that yet. The party line, we tried to study this about 10 years ago, and we didn't get funding. It's one of those things Dr. Welling talked about, it depends on how you frame it. So our hypothesis was the more neurofibromas you have, it's sort of like colon polyps. The more polyps you have, the more likely that one of those polyps is going to go on to become a malignancy. So take the whole intestine, the large intestine, just take it out so you're not at that risk. But we don't have that kind of data yet to say. It makes sense that would be the case, but I don't think we're there yet on the data. Whole body MRI may give us a little bit more information, but it's still going to be over the course of, would like to do it prospectively, so we're going to be talking about 20 years down the road before we have that answer. Yeah. Okay, thanks.